AIDS apartheid, why there's been more than 20 years of progress, but only if you can afford the drugs. And the science of funding, how Britain's EU exit could threaten some of the world's most important research. I'm Martin Stanford. This is Insight. Welcome to Insight. 3 decades of research has seen huge leaps forward in the treatment of HIV and AIDS and the life expectancy of those who contract the virus. But those advances are most readily available to the few, those living in the West, who can gain access to diagnosis and, crucially, the drugs that will save their lives. At the heart of the epidemic, in sub-Saharan Africa, the story is very different. Despite being home to 3/4 of the world's cases of HIV, vast numbers still have no access to treatment. It's been called a modern tragedy of epic proportions, an apartheid in outcomes between rich and poor. Insight Ty Genwright has our main report.
This is where today's HIV/AIDS crisis is most acute. In the Democratic Republic of Congo, Claudine can no longer afford her treatment. This Médecins Sans Frontières clinic in Kinshasa is one of few in DRC that offers free treatment. But 1 in 5 who come here are too late to be saved.
Les petits garçons au lit 14, c'est possible qu'on va les perdre dans les heures qui suivent. Mais malheureusement, l'enfant est vraiment arrivé en très mauvais état général. Nous sommes particulièrement préoccupés pour nous. C'est une sorte de sélection naturelle. Pour les personnes qui sont démunies et qui se voient annoncer le diagnostic VIH, c'est vraiment comme une sentence de mort. La moitié des patients vont tout simplement laisser tomber les bras et attendre la mort.
Those stories, how typical are they? Are they extreme examples?
They are real typical. Every patient is supposed to pay for health services, and this we see it as a barrier for patients getting into the health facilities to access the life-saving treatment in time. They are so basic facilities. Most of the time when you get there, you don't even find qualified staff. There are no medicines, there are no supplies. Patients, when they don't find anybody, they have to be referred to other facilities which are far away from their homes.
So basically, it's just a quick little much of anything.
This is best practice when it comes to HIV diagnosis and treatment. At this clinic in London, patients arrive without an appointment, take a 1-minute test to check their status.
It's a negative result.
And the results come back on the spot. If my test came back positive today, what would happen?
So we would basically kind of make sure that you have all the information that you need, answering any questions about HIV itself, and we would book a doctor's appointment, and that would usually happen within a couple of weeks' time, really.
And then treatment would begin?
Treatment would begin when the doctor and the patient decide that it's going to be best to start. So it could be right away.
The UN estimates that just 57% of people who have HIV know their status. Only 46% have access to antiretroviral treatment and 38% have viral suppression, keeping them healthy and preventing onward transmission of the virus. Well, services like this don't come cheap, but this is the UK's part in a global strategy to raise all these numbers to 90% by the year 2020, which would be a major achievement in containing the virus. Elsewhere in London, this is the culmination of 30 years' work to create an effective vaccine for HIV.
We're not there yet. It's a long-term endeavour. We anticipate that the first vaccines may be partially protective and will be tested in the clinic in the next 5 years. Ending the HIV crisis will require applying all the intervention strategies that we have to hand, particularly looking at ramping up treatment. We know already that treatment makes people less infectious, and so that has an impact on the number of new infections that occur.
But access to treatment remains unequal. And last year, donations from Western governments to the AIDS crisis in Africa fell for the first time in 5 years. This pandemic is now in competition with other humanitarian crises for attention and money. Ty Genwright reporting for Insight.
Well, to discuss that further, I'm joined by Vernal Scott, who's an HIV health specialist and author from the Terence Higgins Trust. Bill Gates, in the build-up to the Durban conference last month, said we haven't turned the corner on AIDS yet. Is he right?
I think he is right. 60% of people infected with HIV still do not have treatment. That is unacceptable. In 2016, he's absolutely right to raise it.
What needs to change if that very constituency is going to receive treatment?
What needs to change is the leadership. Leaders need to prioritise HIV. We have successful treatments today. Nobody needs to die of HIV. It's totally manageable. So far, we've lost 30 million people have died of AIDS-related symptoms. We currently have 35 million living with HIV. As I say, 60% of those living with HIV don't currently have access to treatment.
It was another theme, I think, of the conference, was that funding seems to be drying up, or levels of funding are not growing with the same level of empathy or sympathy as we've seen in previous decades. Why is that, do you think?
Again, it's governments not prioritising the welfare of their own people. If we can get it right as we have, I think, in the West, there's no reason why African countries should still be plagued by HIV in the way that they have. And as well as political leadership, Martin, there needs to be leadership from the religious circles as well. As we know, the Catholic Church prohibits the use of condoms.
Right. That
doesn't help.
And if you were to able to get the Catholic Church to agree that in these circumstances, to prevent the on-passing of sexually transmitted diseases, or in particularly HIV/AIDS, that they would be permitted, would that make a real difference, do you think?
Yes, condoms save lives. You know, before we had successful treatment, it was the simple condom that saved lives, that stopped transmission of HIV. So it's, you know, to have a religious belief, which I respect, but that tells people, you know, not to protect yourself from something that could take your life, we need to address that.
And this is affecting the heterosexual community just as much as the gay community, isn't it?
Predominantly the heterosexual community, particularly in Africa. People should not have to die today or become infected. You know, we recently saw Prince Harry getting an HIV test on British TV. And to me, that's so important, because what he's trying to do is to say we need to normalise HIV testing. We also need to normalise HIV treatment and prevention measures.
Well, let me ask you about prevention measures, because in the West, in America, in the UK, there are discussions now about this particular drug, known by an acronym of PrEP, which it is argued actually is hugely, if not totally, successful in protecting someone who may, even if they do have sexual relations with somebody who's carrying the virus, they are protected. Now, where does this come in the mix? Because it sounds like a bit of a luxury for Westerners, because it's another expense, isn't it?
It is, but believe it or not, you know, PrEP is not available in this country yet, in the United Kingdom.
Well, not on the national health system we have in here. It's available if you want to buy it if you've got money and you can buy it online.
Absolutely, right? But given what it does, and if we look, Martin, at the cost of treatment, you know, once somebody becomes infected, you're talking about scores and scores of thousands of pounds, whereas somebody on PrEP, you don't become infected, so you don't have the on-costs of treatment. So it makes economical sense, as well as medical sense, for PrEP to be widely available in this country, but also abroad.
And you would argue that let's go that route, because the sort of dealing with it after the event has failed. So why not go for the preventative measure?
Absolutely, and you know, we've got to make sure that communities that are currently becoming infected with HIV, to me, that's a logical place to make PrEP available. It'll be much cheaper to prevent than to treat.
Do you think there's still a lack of sympathy or a lack of understanding, or actually a hostility to this, because it's entirely a behavioural-led condition? If you didn't do certain things, you won't get AIDS.
Well,
and therefore, maybe individuals, governments, religious leaders, whoever it might be, don't really have sympathy for it.
Well, you're right. I mean, there is a huge stigma that's always been associated with HIV, and it persists today. It's as abiding as the virus itself. It doesn't help things. People are going to be intimate with each other. We can't stop that. What we can do is give them what they need to prevent HIV and other STIs from being transmitted. That's what we can do. And to me, to be a leader is to take responsibility for the welfare of your people, be it a political leader or a religious one. HIV is here. Let's face how it's transmitted, let's deal with it. And to me, that means investing money, investing in the discourse with those people so they understand what they need to do to prevent transmission.
Vernal Scott, good to talk to you. Thank you.
Thank you.
This is Insight. Coming up, why Britain leaving Europe could be bad news for the advancement of science.